Welcome to The Explainer. In the world of trauma care, the game has seriously changed. Today we're diving into the critical updates from the ATLS 11th edition, and it's all about a massive shift in mindset, one that's built around a single sequence, the X-ABCDEs. Let's get right to it.
In trauma, the margin for error is seconds. That quote just nails it, right? The primary survey isn't some routine you just go through. It's our first, best weapon to stop someone from dying. And it all starts the second they hit the door.
You know, the biggest change here isn't some fancy new gadget. It's a whole new way of thinking. We're moving away from that rigid A, then B, then C checklist that you learn in a classroom, and we're embracing a mindset that's dynamic, that actually works in the messy, chaotic reality of a trauma bay. The goal isn't just checking off boxes. It's actively, forcefully reversing the process of dying.
So let's break down the sequence that drives this entire mindset. The X-ABCDEs. For every single step, we're not just going to cover what to do, we're going to get into the critical why behind it.
And here it is. This is our roadmap. We kick things off with X, for exsanguinating hemorrhage. Then we roll through the classics, airway, breathing, and circulation. After that, we check for disability, and we wrap it up with exposure and environment. This is the playbook for saving a life.
So right out of the gate, we hit the single biggest change, putting X for exsanguinating hemorrhage first. So why? Why on earth would we put that before something as fundamental as airway and breathing?
It's because of this brutal, simple fact. A patient bleeding out will die much, much faster than a patient who can't breathe. A massive external bleed is the most immediate threat to life, and it's something you can see and hopefully stop with your own hands, right then and there.
So for X, your actions have to be lightning fast and decisive. Yeah, you start with direct pressure, but don't just stand there holding it. If that's not working, you escalate. Immediately. Pack the wound, slap on a tourniquet. If you even think there might be a pelvic fracture, get that binder on. The number one pitfall here is hesitation. A delay is deadly.
Okay, with catastrophic bleeding controlled, we can finally move to A for airway. And here, we can actually boil down our initial check to one single, incredibly powerful question.
All you have to do is ask, can they talk? If they can answer you, if they can actually form words, you know a few things instantly. Their airway is open, and their brain is getting enough oxygen, at least for now. But your job is not done. The next question you have to ask yourself is, for how long?
Airway is good for the moment, so we move to B for breathing. And look, this is not about casually glancing over at the oxygen monitor. No, you are on a mission. You are actively hunting for a very specific list of injuries that will kill your patient in minutes if you miss them.
These are the chest killers you have to find and fix right now. A tension pneumothorax, a massive hemothorax, a sucking chest wound, or a flail chest. And here's a crucial pearl. Your monitor can lie to you. Do not get a false sense of security from a normal oxygen level. Trust what you see and hear. If you suspect a tension pneumo, put that needle in. Do not wait for a chest x-ray to prove you right.
All right, now we're at C for circulation. At this point, you have to work under one assumption. They are in hemorrhagic shock. Your job is to find out where the blood is coming from. And you do that by checking 5 spots. Just remember, the floor and 4 more.
So where can all that blood go? Well, first you check the floor. That's the obvious external stuff. But then you've got the 4 internal hiding spots: the chest, the abdomen, the pelvis, and the space behind it, and of course the thighs, which can hide a shocking amount of blood around a broken femur.
And how we resuscitate has been completely flipped on its head. The modern way is to prioritize blood products. We don't just dump in liters and liters of saline anymore, because that just waters down their blood and makes the bleeding worse. We actually allow for a lower blood pressure, what we call permissive hypotension, as long as there's no head injury. And you absolutely have to remember to give calcium.
Next up, D for disability. This is your quick neuro check. And really, there's one number that tells you what to do. If that Glasgow Coma Score, the GCS, is 8 or less, you need to protect their airway. The rule is simple and it is absolute. Less than 8, intubate.
And finally, we get to E for exposure and environment. After you cut off all the clothes and you've rolled them to check their entire body, front and back, your very next move is to get them warm.
Hypothermia is absolutely lethal in a trauma patient. It makes them bleed more, it makes their blood more acidic, it makes everything worse. Just burn this into your brain. Cold kills.
But here's a key thing to understand. The primary survey is not a one-and-done checklist. The best clinicians know it's a loop. It's a continuous cycle. You are constantly reassessing because that patient's condition can change in a heartbeat.
And throughout this whole process, you're using adjuncts, but you're using them strategically. Think of the EFAST ultrasound. It's absolutely essential for an unstable patient to find bleeding fast. But if the patient is stable and you know they're going straight to the CT scanner anyway, maybe you skip it. It's about using the right tool at the right time to get the answer you need now.
We also have to remember that not everybody plays by the rules. Special populations are, well, they're special. Kids can look great with a normal blood pressure right up until the moment they completely crash. The elderly are far more fragile and might not show you those classic signs of shock. You've got to tweak your approach and just have a much higher level of suspicion for these folks.
So after all the steps and the loops and all the special cases, what does this all boil down to? What is the core principle, the real ethos of the trauma mindset?
It's about being able to stand in the middle of absolute chaos and see this one simple, brutal truth. Until you have proven otherwise, every single major trauma patient is actively bleeding, they are unstable, and they are getting cold. That's your starting point.
And what that means is you have to let go of the need for a perfect diagnosis in those first few minutes. It's a luxury you just can't afford. You don't need to know the exact name of the artery that's torn to know that you need to stop the bleeding.
You need to act. That's the bottom line. Your job isn't to be a detective, it's to be an interventionist, to systematically and aggressively reverse the process of dying second by second. That is the trauma mindset, and that's how you save a life.